Hi, so today's video will be a video series about the basics of EKG in a little bit more detail. In previous videos, I might have done a video about EKG and pertaining to family medicine, but I'd like to start with today's video, really starting a series with a multitude of videos about EKG, about the abnormalities in EKG and how we can distinguish one EKG abnormality from another, whether it's pertaining to arrhythmias or hypertrophy or bundle branch blocks and so forth. So before we start off, the first video will be a little bit longer than usual because this first video will be about the basic physiology of the heart from an electrical perspective, to understand about the function of the heart as a revision, as well as some tools that are, or let's say some components of the EKG, understanding these as well, such as LEDs and what are the purpose of LEDs. So in summary, we'll be revising the physiology of the heart, as well as some basic information about LEDs and how they work, before we go on with the next video talking about EKG abnormalities such as hypertrophy. All right? So let's start ahead. So as you can remember, the heart, its function is to act as a bloody pump. It's acting as a pump 24/7. Its purpose is to transfer the blood to all the organs in the body, or otherwise known as the cardiac output. And the organ that needs the most amount of blood is, of course, the brain, followed by the liver and so forth, right? Of course, in order for the heart to act as a bloody pump 24/7, it needs two things. One is that it needs oxygen, which it receives from the coronary arteries, from the blood. And of course, in order to receive this blood, the heart has to be acting as a pump. So when the heart is pumping specifically from the left ventricle towards the aorta, a lot of this blood will go towards the coronary arteries first to supply the heart. And then it will go towards the other organs. And of course, in order for that to happen, you need oxygen from the blood. In order to get that blood flow, in order to get that blood pumping, you also need a second requirement, which is electricity. That is how the heart functions as a pump. So it can pump itself blood. This blood can go towards the heart itself, through the coronary arteries. It needs nutrients, it needs oxygen for energy. And then it can transfer the remaining blood all towards the brain, towards the liver, towards the kidney, and so forth, okay? But for all of that to happen, in order to get oxygen to do its function, it needs the very key thing, شيء أساسي, اللي هي electricity. Where does it get this electricity? From what is otherwise known as the pacemaker cell. The most infamous and the most common by far, and really in normal cases, the fastest pacemaker cell is the SA node in most human beings, okay? What is SA nodes? We'll come to it shortly, okay? So that's the need of the heart. Now, let's talk about electricity, all right? Let's talk about how is depolarization and how is repolarization works. How does it work exactly? How are we able to produce an action potential or an electrical current or a wave of depolarization? The same meaning, okay? So let's review very quickly. So here we have one cell and we have another cell next to it, okay? Let's assume these two cells are your myocardial cells, okay? These are the types of cells that when they are depolarized, they contract. When they repolarize, they relax. The cells that make up the right atrium, the left atrium, the ventricles, all the chambers of the heart, okay? So when we have a myocardial cell, you see it will be depolarized. But how? How is it depolarized? From the action potential that it receives from the SA node. The SA node is a node composed of pacemaker cells. They are modified cells, or let's say modified pacemaker cells, whose function is to continuously, 24/7, without any stoppage, produce an action potential or a pacemaker potential all the time. And this pacemaker potential, once it's produced, it will go towards the myocardial cells, all right? So it will go towards this myocardial cell. And when we say that this action potential reaches this myocardial cell, it means it will cause depolarization. What does depolarization mean? It means these pluses, these cations, such as sodium and calcium, they will go from outside to inside. How? Through a pump. maybe sodium-potassium pump, maybe a sodium channel or a calcium channel, no matter what, there will be a pump or whatever channel that will allow the sodium and the calcium, the cations, to go from outside to inside, okay? And what that means is now the inside of the cell, which is normally negatively electrically charged, now it will become positively charged. And thus, this will generate a depolarization wave or an action potential. And the end result of this depolarization in the myocardial cell, the end result is contraction. And here's the thing, this depolarization will not stop at one cell. It will propagate to another cell. So we have another cell in which it will also receive this wave of depolarization. And it will also be depolarized. It will thus allow the cations to enter inside, and thus the end result will be contraction for this cell as well. And at the same time, it will propagate this action potential, this wave of depolarization, it will propagate it to the other nearby cells next to it, and so forth. Spread it, okay? Now, this is depolarization. What about repolarization? The same concept, but in reverse. In repolarization, the positive cations inside of a cell, specifically potassium, they will go out. They will go from inside to outside. And thus, the inside of the cell will go back to its previous normal state, which is negatively electrically charged. And when we have positive cations leaving from the inside to the outside of the cell, this will cause repolarization. What is the end result of our myocardial cell? When they're repolarized, relaxation, okay? Relaxation. And the same concept, it will spread this repolarization wave, this action potential of repolarization, it will spread it to other nearby cells, okay? Now, this is the basic concept behind depolarization and repolarization, and how the end result is contraction, relaxation of the four chambers of the heart. Who produces, who sends this wave of depolarization? Who gives it electricity? The pacemaker cells. What causes contraction and relaxation? The myocardial cells. And what is the cell that is this chain right here? What is the special type of cells that will take this action potential and it will conduct it to other areas so they can also be depolarized and thus contract it or relax it? Who are these special type of cells that will act as messenger? These are known as conducting cells. So, you have cells that create electricity, pacemaker cells. You have cells that cause contraction and relaxation in response to this action potential, myocardial cells. And you have this chain, this special type of cell that will take this action potential and send it to the other nearby cell, known as conducting cells. How many types of cells did we just mention? 3. So, we just now summarized the 3 special type of cells that is found within the heart. P, pacemaker, C, conducting, M, myocardial cells, okay? And each of their function. Now, let's now talk about a little bit about EKG. Now we're going to enter into the basics of EKG. What is an EKG? Another term, ECG, the same meaning. What is electrocardiogram? Well, it is a tool like any other. It is a tool that is useless unless a person knows how to read it, or a person knows how to assess the finding, or if a person knows the reason why he's ordering it. No doctor, no physician orders an EKG as a screening tool. It is a tool that is utilized when it is appropriately indicated. So if a person has chest pain, palpitation, shortness of breath, according to history and examination, you might order an EKG to exclude abnormal findings, okay? So it is a tool like any other, like a chest x-ray, okay? So how will EKG help me? How does EKG help me in diagnosing cardiac diseases from one perspective? Here, the thing about EKG, they will not show me the function of the valves. It's not like an echo. It's not like an echo where it will show me the heart physically and its function. It's not like a chest x-ray where I'm visualizing the heart. No. ECG helps me in visualizing the electrical activity of the heart. So I want to know the electricity, that is going throughout the heart. I want to know the conduction system. I want to know how they're functioning, because they reflect the function of the left ventricle and the right ventricle and all the other chambers of the heart. Meaning, in another way, when I say, for example, that the SA node is functioning and the AV node taking the action potential and it delays further conduction. When I'm saying that the SA node is sending its action potential normally and it's causing depolarization, repolarization. What does that mean for me when I see this finding on an EKG? It means when I see the SA node is functioning well, that means the right atrium and the left atrium, they're contracting properly and they're the first one to contract, followed by the right ventricle and the left ventricle. So in summary, the electrical activity of the heart, we are able to record it via EKG. It will tell me whether there's any problem with electricity, and thus at the same time, if there's a problem with electricity, there's also a problem with the function of the heart. From the perspective of conduction and relaxation, from the timing, from the amplitude, from the duration, okay? So that's the purpose of the EKG, just from knowing the electrical activity of the heart that's being recorded, okay? Now, in order for us to record the electrical activity of the heart as a video, we need cameras, you know? We need these cameras with us. These cameras are otherwise known as LEDs. What are LEDs? Well, if any of you searches EKG on Google, you'll know that the EKG is a machine. It's a portable machine with a lot of wires attached to it. And at the end of these wires contain hooks. These wires and hooks together make up your LED. LEDs are your cameras. They're the ones that record the heart. They record the heart at different perspectives, at different locations, or at different angles of orientation. And they give me the electrical activity of the heart. They give me a view of the electrical activity of the heart from different perspectives, okay? So they are cameras that will allow us to record the electrical activity of the heart. And what are these LEDs? How many cameras do we have? How many cameras are going to record the heart from different perspectives? We have a total of 12. 6 of them are limb leads. What does limb lead mean? It means LEDs that will attach itself to the person's right arm, to the person's left arm, as well as the person's left leg. So we will have LEDs, a slack from the EKG machine that will attach itself to the right arm, to the left arm, and to the lower leg to view the heart from different angles. These are 6 LEDs. Then the other remaining 6, making up the 12 LEDs, are your precordial LEDs. LEDs in which we will attach them in the chest. We'll have one LED, V1, which will attach it on the right side of the chest, fourth intercostal space, while the other remaining precordial LEDs, V2, V3, V4, V5, and V6, they will be attached on the remaining left side of the chest towards this direction, okay? So this is the number of LEDs that we have, 12 LEDs, 6 limb LEDs, and 6 precordial LEDs, okay? Now, what are these LEDs composed of? They are composed of 2 things, a positive electrode and a negative electrode. And since these LEDs act as cameras, their purpose is to record the electrical current, the electrical potential that is arising from the SA node firstly, and it's spreading towards the remaining chambers of the heart. So this is a drawing of the heart where we have an SA node that's generating an action potential and is going inferolaterally towards the heart. So any of you saw a case or you heard of the term vector. If you ever heard of the term vector or mean electrical axis, it means the average action potential direction, or the average direction that these action potentials take. You see, in reality, when the SA node generates an action potential from 60 to 100, when they're generated, they go all over the place. But there is one direction they take on average. The majority of them go in one direction on average, which is inferolaterally. So it will go towards this direction. And since we have this vector right here, this vector is exactly what we're recording from the LEDs. they are recording this action potential, this vector, which represents the mean electrical potential that is going towards this direction and depolarizing all the chambers of the heart at the same time. Okay? So, let's go back. The lead is composed of two components, positive and negative electrode. And while we talked about the vector and all that stuff, you see, when we have a wave of depolarization, or an electrical current, or a vector, or an action potential, the same meaning. When we have a wave of depolarization going towards a positive electrode, this will cause a positive deflection, okay? Meaning upward deflection, okay? However, when we have a wave of depolarization, when it's going away from the positive electrode, it will cause a negative deflection, okay? That's very important because when we read the EKG, from many different leads, not all of them will look the same. Some of them may look inverted. Some of them may look opposite of one another. So that's why we want to learn these things. So a wave of depolarization towards the positive electrode, positive deflection. Away from it, negative deflection. So what about repolarization? When you have a wave of repolarization, when it goes towards the positive electrode, it will cause a negative deflection. Wave of repolarization towards the positive electrode, negative deflection. However, when we have a wave of repolarization going away from the positive electrode, it will cause a positive deflection. عكس الكلام, the opposite of what we said on the depolarization, okay? This is very important to understand as a concept because as we'll know in the next upcoming videos, every lead will show a slightly different reading, if not complete opposite reading from the other when we measure each lead, okay? All right, so now that we've understood this concept and how these leads, how the reading will look like with each lead, now let's talk about each lead. Where are they placed? Where are these leads placed? Now you see, in reality, when we have these aslag, these wires from the EKG machine, you see the EKG machine, it will produce a paper for us. A paper that looks like any other paper, a rhythm strip, okay? Printed from the machine. In order for this paper to be printed, we need to attach a couple of leads on the person's body. So, we're going to attach a lead that's going to be on the right side, on the right arm. We're going to have a lead that's attached on the left arm, and a couple of leads that are attached on the left leg. Each of their purpose to record the heart from a different angle of orientation, or from a different position. So, what we have here is the heart. And surrounding it are a bunch of leads at different angles. You see, what we're looking at here, more specifically, is a term known as your cardiac axis. Cardiac axis, you can think of it as a clock. We have the heart, and what's surrounding it is basically a clock, right? So, let's revise together what exactly happens. What exactly happens with the electrical activity of the heart? How does the heart is able to produce atrial depolarization as well as ventricular depolarization in an organized manner? Once we revise the function of the heart from an electricity perspective, we'll be able to also understand the purpose of the EKG and how it produces a specific reading, okay? So let's revise. But for now, this is the cardiac axis in which we have a bunch of leads attached at different areas, okay? Let's see what happens while the heart goes through one cardiac cycle, all right? Systole and diastole, okay? So let's revise. It's a story. First, the SA node automatically will produce a pacemaker potential or an action potential, okay? Between 60 to 100 beats per minute, all right? Someone might ask me, Nawaf, do we have other pacemaker cells besides the SA node? Actually, yes, you do have one. You have one in the ventricles, you have one in other areas of the atrium besides the SA node. You have other pacemaker cells, however, the SA node will always be the one generating the action potential first. and sending it further. Why? Because the SA node is the fastest one. This is the one that generates the fastest amount of action potentials, and it will overwhelm its competitors. So normally, when people refer to a pacemaker, they don't refer to a pacemaker cell in the ventricle or a pacemaker cell found in the atrium besides the SA node. No, what they refer to a pacemaker cell is the fastest one, the fastest competitor, which is your SA node. Okay? So let's go back. The SA node generates the action potential. And once it generates this action potential, it will depolarize the right atrium first. And once the right atrium is depolarized, it will subsequently contract. Alright? Then, once the right atrium is depolarized, there is a shortcut. This is Shara Malik Abdullah. It will send this wave of depolarization from the SA node. It will send this action potential, this wave of depolarization, it will send it through this shortcut pathway towards the left atrium as well. And therefore, the left atrium will depolarize and it will contract as well. So, right atrium will be depolarized first, then followed by the left atrium as well, thanks to the action potential that it received from the SA node. What is this reading it will give us on an EKG? It will give us this reading. So, the right atrium is depolarized first, so it will give us this wave, this positive deflection, alright? Then, the left atrium is depolarized after the right atrium, it will give us this remaining deflection. If you notice right here, we just created a positive deflection, alright? We put a lead, for example, towards the wave of depolarization. We put a lead that is recording this wave of depolarization right in front of it, and it produced for us a positive deflection. This positive deflection, they gave it a name. It is known as a P wave. This is a P wave. This P wave reflects atrial depolarization. But to be more specific, if I put a line, atrial depolarization, that means the first half of this wave represents right atrial depolarization because it's the first one to be depolarized. Then the second portion of this wave, the terminal portion, represents left atrial depolarization. Why? Because the left atrial, this is the one to be depolarized after the right atrium has been depolarized because it's closer to the SA node. Okay? So the P wave represents specifically right atrium as well as left atrium depolarization. Okay? So it will give us this finding, especially when we have a lead that is recording towards the vector, towards this direction. We'll come to it shortly. Okay? Let us continue our story with the conduction system. So, this is atrial depolarization. Then this action potential, it will go all over the place, but it will stick towards one average direction, inferolaterally, okay? Now we will come towards the AV node. The AV node, it will receive this action potential, and it will delay it. It will not send it towards the bottom. No, this AV node that is found in the AV junction, the junction between the atrium and the ventricle, this AV node will take the action potential and wait for 0.1 millisecond. This is known as conduction delay. It will wait for that long. Why? To allow for the ventricles to relax. Because the right and the left atrium, they will be depolarized and contract, and they will send the blood towards the right and the left ventricle. So now the AV node, it will just tell it to wait. Let me have the left and the right ventricle, let me have these chambers be filled with blood before I send this action potential downwards, okay? So the AV node will have a conduction delay of 0.1 millisecond. After that, it will send the action potential downwards, okay? Once the ventricles have been filled up, tamam? Alright, now the AV node will send it towards this line, the bundle of His, BOH, the bundle of His. And when this action potential reaches towards the bundle of His, this will cause septal depolarization. What is septal depolarization? Yani depolarization of the interventricular septum. And remember, when we say depolarization, we mean this term that we talked about before. So there will be septal depolarization. And with the septal depolarization, you see the depolarization, it will not go inferolaterally, it will not go towards the right, it will be in a neutral state. This means the wave of depolarization, it will go all the way towards the septum. Neither to the right, neither to the left. So it will produce for us what is known as a Q wave. So we will have here what is known as a Q wave, okay? This is known as a Q wave, ممتاز, in which it represents septal depolarization. It will depolarize the septum in the middle. And this wave of action potential, this wave of depolarization, it will not go towards the right or towards the left just yet, okay? It will produce for us a negative deflection known as a Q wave, okay? So now the bundle of His will then send the action potential towards two branches. The right bundle branch as well as the left bundle branch, okay? When it sends this action potential towards the right bundle branch and the left bundle branch, it will depolarize the right and the left ventricle, finally. So the right and the left ventricle, they will be depolarized. And which one do you think is bigger, the left or the right ventricle? The left ventricle. That's why the electrical activity of the ventricle, it's more specifically the left one, because the left one is more dominant than the right one. It's much bigger in size, thus it will be more depolarized and more contracting as compared to the right ventricle. So it will produce for us a positive deflection going inferolaterally, so towards this direction. This is known as your R wave. This is the R wave, okay? And then, once this action potential reaches what is known as the Purkinje fibers, found in the remaining walls of the right and the left ventricle, now the Purkinje fibers will cause depolarization of the remaining walls of the right and the left ventricle laterally. So we're towards this side and this side. And this will cause a remaining negative deflection that will go towards the baseline, meaning it will produce this, the S wave. So this S wave represents the end part of ventricular depolarization, in which we have a wave of depolarization reaching the Purkinje fibers here and here, where it will go towards this side and it will go towards this side. Neither direction is preferred. It will go right and left. So this will produce for us a negative deflection, in which it will then eventually reach towards the baseline. The baseline meaning the flat line. This is meaning of the baseline, okay? Or in EKG, the isoelectric line. Okay? So this right here, this complex, this interval QRS together, the QRS interval and the complex, all of them together, they represent ventricular depolarization, but specifically left ventricular depolarization, because the left ventricle is much bigger than the right ventricle. Thus, it will receive more action potential, and that's why, Jama'ah, the average action potential's direction will be inferolaterally towards the left. This is important, okay? Especially when we look at our cardiac axis. Because, Jama'ah, because if, for example, you have right ventricular hypertrophy, okay, this means that now the majority of this action potential, instead of it going inferolaterally towards the left, it will be deviated. It will come towards the right. And this will give us an abnormal finding. This is known as an axis deviation, and we'll see that in upcoming videos, okay? So this is what's important to know, is that the QRS represents left ventricular depolarization. You have Q, specifically Q, representing septal depolarization, R, right ventricular depolarization, S, representing the remaining part of the ventricle being depolarized towards the right and left without a specific direction, okay? Mumtaz. Then eventually, once depolarization is finished, next comes repolarization. And remember, when there's repolarization, we talked about it here before, when there is repolarization, that means the positive cations, they will come out. They will be in the opposite direction. So, do you recall this arrow? Let's assume this arrow is the direction of repolarization. Depolarization towards this direction, inferolaterally towards the left. But repolarization, the opposite direction. Now the cations will come out towards this direction. So now the right and the left ventricle and the right and the left atrium, they've been repolarized a long time ago. So, when there is a wave of repolarization, okay, and it's going towards this direction, it will produce the final wave, which is known as your T wave. So T wave here represents ventricular repolarization, specifically the left one. Mumtaz? So it is known as the T wave. Alright? So now what we have here is the normal EKG tracing, or normal sinus beat, in which arising from the SA node produces a P wave, QRS interval, and a T wave. Okay? This represents atrial depolarization, ventricular depolarization, and then ventricular repolarization. So one could ask me, where is atrial repolarization? Atrial repolarization is not found here. Why? Because it's hidden. It actually occurs within the QRS complex. Because, of course, the atrial repolarization will occur earlier. But you see, the atrial repolarization, it occurs within the QRS complex, but it's hidden because the QRS complex is so much bigger. So it will hide the atrial repolarization. That's why we don't see a wave reflecting atrial repolarization. Instead, we only see a wave that comes followed after ventricular depolarization, which is the T wave, which represents ventricular repolarization. Mumtaz? All right. Now, one more question so we can end our video, and the most important bit. Nawaf, how come this P wave is positively deflected? Why is there a positive deflection? Why is there a negative deflection? Why is there a positive deflection in R wave? Why is the R wave so much bigger than these two? Why is the T wave positive deflection? Since it's repolarization, why is that? Well, remember what we mentioned before? Remember what we mentioned about the electrodes? How lead's composed of positive and negative electrode, and how depending on the direction of the action potential, it might give you a positive or negative deflection. You remember that? Well, this will explain why we have one positive deflection and one is a negative deflection, okay? This will explain it, okay? All right. So in order to explain it fully, we will have to look at each lead, all right? Remember, this average vector, this V here, Mumtaz, this vector represents the mean average action potential that is going towards a specific direction, which is inferolaterally, right? So our electrodes of the EKG that is attached in the person's body, they will record this vector, this specific vector, at different angles, Mumtaz, at different angles of orientation, which is meant by different positions, different location, okay? So, again, this is the heart. SA node, AV node, bundle of His, bundle of branch, Purkinje, whatever. 4 chambers of the heart, right and left atrium, right ventricle, left ventricle, whatever. This is the heart. And surrounding it is a clock, known as your cardiac axis, where we are trying to assess, we're trying to have different electrodes placed at different locations to record the mean electrical activity of the heart, the mean electrical vector, which is going inferolaterally, representing depolarization. Mumtaz? So, we have it at different degrees, so let's go one by one. We have at 0 degrees lead 1. Lead 1 is a limb lead that is attached on the left arm. Mumtaz? Specifically, the positive electrode of lead 1 will be attached on the left arm. Alright? Well, the negative will be on the right arm, for example. This one will be placed at the left arm at 0 degrees, where it will record the vector inferolaterally. And what will lead 1, how will the EKG reading of lead 1 look like? This reading right here. Mumtaz? طيب. Now go plus 30 degrees, plus 60 degrees. At plus 60 degrees, lead 2 will show up. Lead 2 is placed on your, where is lead 2 placed at? Lead 2 is placed on your left arm. Not your left arm, your left leg. It is placed on your left leg. Specifically, its positive electrode is placed on its left leg. And it will record the vector from an angle of 60 degrees. And it will especially give us this reading right here. Mumtaz? This is lead 2, another limb lead. Then at plus 90 degrees, you have AVF. AVF is another lead. It's another limb lead, but augmented. It is a limb lead that's also attached on the left leg. And it will record the heart at plus 90 degrees of angle. Mumtaz? Then you go above, plus 120 degrees, lead 3. which is another limb lead. At plus 120 degrees of orientation, it will also record the heart at that angle. Now, before we continue, if you realize lead 1 is recording the heart at laterally. It's recording it laterally. Lead 2, AVF, and lead 3, they're recording the heart inferiorly. So let's imagine the heart. The heart here is placed on a horizontal plane, okay? On a horizontal plane, ممتاز? It's placed on a horizontal plane in which the lead 1 will record the heart from a lateral perspective. Lead 2, AVF, and lead 3 will record from an inferior perspective. And the remaining leads we will see, ممتاز? But just to summarize, so lead 2, AVF, and lead 3, they are known collectively inferior leads, inferior. Lead 1, joining with 3 other leads that we will know shortly, they join lateral leads. ممتاز? So let's continue. Plus 150 degrees, plus 180 degrees. Then we reach minus 150 degrees, which is AVR. AVR is the only limb lead that is attached on the right side of the arm. The right side of the arm, and thus records the right-sided view of the heart. ممتاز? This is known as AVR. So, we have AVR at minus 150 degrees, recording the heart from the right side. Then, minus 120, 90, 60, minus 30 degrees, we have AVL. AVL, as in left arm, this one will record the heart from a lateral perspective, the same as lead 1, but at minus 30 degrees. At what? Minus 30 degrees. So, let's summarize. How many leads do we have here? We have a total of 6. So now we have the other remaining 6, which is your precordial leads, which is V1 all the way to V6. Attach it on your chest. Where will they record the heart? Well, let's now imagine the heart. Instead of a horizontal plane, they are a vertical plane. ممتاز? And at a vertical plane, we now have V1. V1 will look at the heart from the right side. So it will join with AVR, okay? So these two are your only leads that record the heart from a right-sided perspective. V1 will record the heart from the right side. V2 and V3 and V4, V2 and V4, they will record the heart interiorly. And they're the only one that is not seen here that will record the heart from an interior view. Okay? From an interior view. Then, the last remaining precordial leads, V5 and V6, they will record the heart from a lateral perspective. Thus, V5 and V6 will join lead 1 and AVL as lateral leads. Lateral leads that record the heart from a lateral perspective. So, we have inferior leads, 2, 3, and AVF. We have right-sided leads. We have right-sided leads, AVR and V1. We have lateral leads, 1, AVL, and V5 and V6. And then we have V2 and V4, your interior leads. ممتاز? Your interior leads. The precordial leads, V1 and V6, they view the heart from a vertical plane. قدامها. One left, one right, one interiorly. The limb leads, they view it in a horizontal plane. So the same idea. One on the left, one on the right, one at the bottom. Okay? So this is your cardiac axis. Okay? And this is why when we look at a lead, such as lead 2 is viewing the heart inferiorly. And if we look at this vector, this positive electrode of lead 2 is going to see a vector in electrical potential coming towards it. And if there's a wave of depolarization, if there's a vector coming towards it, it will produce a positive deflection. If there's a wave of repolarization going away from the lead 2 positive electrode, this will produce a positive deflection. That is, if a wave of repolarization is moving away from it. ممتاز? And if we have a wave of depolarization, D, running away from lead 2's positive electrode at this angle, it will produce a negative deflection. ممتاز? So this is why this reading, you can imagine it, this reading from lead 2, understanding this concept and understanding its position, recording this vector, it will give you this reading, leg 2. However, AVR, ya Jama'ah, AVR will give you the opposite reading. Mumtaz. It will give you the opposite reading. So it will look like this. AVR, right-sided lid. Since it's placed here and the vector, the depolarization is going the opposite way, it will give us the opposite image. So P wave goes this direction. Mumtaz. Depolarization goes this direction. But AVR is placed on the right side. So we have a wave of depolarization that's running away from the positive electrode of AVR. So we have an inverted P wave. Normal. Then you have a Q wave going up, an R wave going down, an S wave going up. And then you have a T wave that's inverted. This is seen in AVR. This can be seen in V1. Mumtaz. So that's why each one looks different from the other. Mumtaz. So that's pretty much it. And of course, one last thing before we move on. Before we move on to the next video, I just want to mention to you one last thing. And that is back to the reading. So we have a P wave, Q, R, S, and then a T wave, right? Now, if you notice, between each of these waves, there's a flat line. There's a flat line between the Q and the R wave, or the Q and between the P and the Q wave, right? Or let's say between the Q and the R wave, whatever. There's a flat line here, right? There's also another flat line between the S wave and the T wave. What are these flat lines? Well, these flat lines are otherwise known as segments, okay? We have what is known as here, segments here, Mumtaz. This is known as segments, in which we are assessing really the duration between one action and the other. So for example, this is known as your PR segment, which represents the end of atrial depolarization to the beginning of ventricular depolarization. That is what is meant by a segment, Mumtaz, or a segment here, ST segment, which represents the end of ventricular depolarization to the beginning of ventricular repolarization, Mumtaz. Of course, we need to know these things because these segments can be prolonged, and these segments at the same time can be shortened. Some of them may be elevated, some of them may be depressed. They should be flat. These segments should be flat. Why? Because if you revise the story we mentioned before, from SA node to AV node and whatnot, if you revise the story, you should know, following atrial depolarization, the action potential from the SA node will come to the AV node. And if you remember, the AV node, it causes a conduction delay. It will not send the action potential for 0.1 millisecond, right? Thus, it will have this flat line, right? That is normal, Mumtaz. And as for the ST segment, it should also be flat, because following ventricular depolarization, which occurs, by the way, very fast, and it's actually very narrow, the QRS complex, but it occurs very fast. Once this ventricular depolarization finishes, there will be a flat line. This flat line in which repolarization will not occur immediately. It will take some time before repolarization will occur. So this is what the ST segment represents. It should not be elevated and it should not be depressive, Mumtaz. So we should know about these things as well. And one more thing as well, We're talking about segments, right? This is a PR. And this is an ST, Mumtaz. So we have a PR here, and we have an ST segment here. These are known as segments, but there's another term known as intervals. We have a PR interval, and we also have an ST segment. An ST interval, or let's say more specifically, QT interval. What is the difference between a segment and an interval? The only difference is one is longer in distance than the other, meaning, when we see PR segment, we mean from the end of atrial depolarization to the end of, or to the beginning of ventricular depolarization. A PR interval basically means the same idea. It means from the beginning of from the beginning of atrial depolarization to the beginning of ventricular depolarization. So we have a longer distance where we start from the beginning. Intervals start from the beginning of one action, but PR segment, They start from the end of one action, then towards the action, or then towards the beginning of another action. ممتاز? So that's the key difference. Here we have a segment, but here we have an interval. Here we have an ST segment, but then we'll have an interval like this. From the beginning of ventricular depolarization, from the beginning of the Q wave, towards the end of ventricular repolarization. This is known as QT interval, in which this has a longer distance as compared to the ST segment. ممتاز? So that's another term to keep in mind, and we'll revise it again in the next upcoming video to complete the picture. Why we should know about all of these things? Why should we know this one is bigger than the other or whatever? We will come in the upcoming videos, alright? For example, the R wave, it will always have a larger amplitude, meaning it will always have a greater positive deflection as compared to P wave. Why? The left ventricle is bigger than the right and the left atrium. So naturally, more action potential come towards it, so we'll have a better positive deflection or a bigger positive deflection than the P wave, for example. ممتاز? So that's the idea. We just wanted to revise the complete reading, and we will revise it again in the upcoming videos. ممتاز? So that's pretty much it. ممتاز? Now we've revised the basic physiology of the heart, as well as the LEDs, and each of them. And of course, here's a summary of them. Inferior LEDs, lateral LEDs, right-sided LEDs, and anterior LEDs. That's the summary of all the LEDs. And now, I just want to mention that in the next video, we will be talking about how to develop a search pattern. How will we develop a search pattern for an EKG? How will I search? What do I look for first? There's a step-by-step search pattern. We will look into it step-by-step with each video. And we will start with knowing the heart rate and whatnot, as well as knowing when is a ventricle hypertrophied and how we will look at an EKG. We will look into that on the next video, alright? So that's pretty much it for today's video, and we'll see you in the next one.